I'd like to thank the Planning Committee for everything that they've done for this fantastic meeting and for inviting me to share the stage with so many wonderful colleagues. And I have a presentation that I hope will follow very nicely on Pam's. I also have no financial disclosures related to this work. The work that I'm going to talk about has been supported by a number of foundations, including the ACS and the NCI, and the work of many, many colleagues over many years. So what I'd like to do this morning briefly is provide a background for the rationale for family psychosocial risk screening. So Pam foreshadowed the importance of the family voice, and that is really the focus that I will be taking in this work today. We have a model called the Pediatric Psychosocial Preventative Health Model, affectionately known as the triple PHM, and that guides some of the work that we've done on psychosocial screening. I'd like to tell you about that and think a little bit about the implications of that for interventions to support children and families. I'm going to specifically talk about a screening measure that we've developed, the Psychosocial Assessment Tool, or the PAT, and conclude with some gaps in our knowledge and next steps. So the advantage of coming on the second day is I can just refer to other people's talks and say, I agree, okay, let's move on. So I don't want to be repetitious, but I do want to really drive a couple of points home. So children live in families, and I've heard a couple of times over the past couple of days that cancer is really a family disease, and that is the bias from which this work comes. We really think about the child in a social ecological context, and that if you're familiar with social ecology, that first inner circle of influence is really at the level of families. And what we're trying to do as we think about what types of psychosocial care to deliver is identify what those hotspots are, in a sense, in that social ecology, so we can deliver interventions specific to the problems that a particular family may experience. Again, consistent with what's been said, there's a span here, and we see a lot of resilience in our families. And this isn't to minimize the pain that people have, but is to say that we're basically coming from an assumption that people are resilient. We see remarkable resilience in our families. So this diagram sort of goes from PTSD to post-traumatic growth, and the normal curve is probably not a bad estimate, not a scientific graph, obviously. There was a paper authored by Rebecca Seelove and colleagues a couple of years ago that showed, I think quite dramatically, how infrequently evidence-based psychosocial care is being delivered to children and families in COG institutions. There's a number of facts in there to think about, but only 9% of families were offered empirically supported interventions in the first month after treatment. So I think this is highly consistent with the kind of things that we talked about yesterday. So we need to figure out how to do this in an inclusive and effective manner to understand family risks. And one of the things that has always bothered me in administrative roles that I had previously was that who gets care depends on things that have very little to do with what the family is expressing. Unless, of course, the family expresses very directly, we need help, either behaviorally or verbally. Otherwise, who gets help may depend on referral patterns from oncologists, from nurses, from other people. And we know that many families do not receive the care that they need and the care that they could benefit from. So many of these points have been made. Obviously, we've heard a lot about child reactions, parent reactions, including traumatic stress responses. I'm not going to be talking a lot today about post-traumatic stress, but that is proven to be a very important and very helpful model in working with children and families. We haven't heard too much about siblings, so I want to just draw your attention to that. The literature reflects perhaps family dynamics as well, in that we don't often study siblings. But when we do, we know that they also are very impacted by the experiences that are going on in their families, and that those persist over time as well. there is indeed a trajectory of improved functioning, and there's good literature to support this, that what we see is at the point of diagnosis, distress escalates quickly and high. And over time, a typical pattern is that the stress lessens. What we're particularly interested in, however, are those families for whom distress does not lessen, and perhaps for which it even escalates over time. So I'll show you some data on how many families we think that might be, and it may actually be less than what you're worried about, but it is, I think, a nice way to think about it. Pre-illness functioning, to the extent that we can know that, everything is retrospective, does predict longer-term outcomes. Mary Jo Cupps yesterday was very modest about her research. She has one of the major longitudinal studies following families for 12 years. Very remarkable research. We also know that social isolation is a major predictor of distress, and I think is something for us to think about, because I think in some cases those are areas that we can have an effect. And as we heard yesterday, that cancers that impact the central nervous system are particularly remarkable in their impact on both neurocognitive and psychosocial difficulties. So, how can we do this realistically? I would argue, and I think many people agree, that we need a way to screen all families so that we can figure out what's going on quickly. So how can we screen? Just a brief categorization of some of the ways. One is a battery of measures. Okay, so I'm a psychologist. We all love lots of measures, right? What are the advantage of validated measures? They're validated. You can identify specific problems with some degree of certainty, but it adds up quickly in terms of length and patient burden. We also have the very brief screeners, and the distress thermometer is the main one in that regard. I'm sure many of you are familiar with it. It's a sibling to the pain scale. Also has additional categories that people can check off in terms of where they're having difficulties. It's a individually oriented but very quick, how are you doing right now? How much distress do you have? There are structured clinical interviews which give a lot of rich information. They're not widely used, and you can imagine why, because of the training and time involved in providing them. There's short standardized instruments. I'm going to be talking specifically about the PAT, and there may be other ways that people are screening, although I can't find them in the literature. So here's the Pediatric Psychosocial Preventative Health Model. This is based on a public health model, and at the base, I'm not sure if I have, at the base of the model are what we call universal families. These are families in the context of cancer here that are distressed but resilient. Targeted is the middle tier of the pyramid, and these are families that have acute or elevated distress and other risk factors. So I think about things in the context of cancer where perhaps a child who had ADHD before they were diagnosed. I think about a family that has considered divorce, where there's things going on here that we know could complicate things. And then at the tip of the pyramid, the clinical or treatment families where you have severe escalating persistent distress. Those are the easiest families to recognize. This is not drawn to scale, and I'm going to talk a little bit more about that. It's drawn to look pretty as a slide. But the intervention options, which I'll say more about later, are down here. So what do we do for universal families? What do we want all families in a treatment center to receive? Psychoeducation, family support. I would also argue it's important to continue to screen and watch and evaluate families, because these are not rigid lines between these levels. There's a possibility of moving. The targeted families, I think, this is where I think we can really make a difference, because this is where evidence-based treatments, such as problem solving, and a range of other things that we know work to lessen the distress of children and families, can be brought to bear. The clinical and treatment families are the most difficult to treat. They're going to require the expertise of a behavioral health specialist. Okay, so now let me tell you about the PAT, or the Psychosocial Assessment Tool. The PAT is a brief parent report screener of psychosocial risk. We have what we call all literacy versions, which are at a 4th grade reading level now in English and Spanish. There's been tremendous interest in the PAT, and you can see that we have, there's research projects going on around the world. It's been translated into a number of different languages, adapted for other English-speaking countries, and I think importantly used at 52 sites in the United States right now, 27 states, and 30 international. Most of these uses are in oncology, although there's adaptations that are out there for other diseases as well. So I have some paper and pencil copies of the PAT if anyone would like to see it in English as well as Spanish. But let me tell you a little bit about how we got there. On the left here are the domains that we decided were important. And gosh, this was in the mid-1990s. This takes a long time to get to this point. And it was actually instigated, if you will, by hospital administrators who were saying to me, oh, you have too many social workers on your team, or if somebody leaves, we're not necessarily going to refill the position. And I was like, we've got to find a way to show what we're doing and try to get there quickly. So these are all of the things that we thought. This was a multidisciplinary team, came together around the table. These are all of the things that we thought were important. And we went through I think a very good process of going from a big stack of everybody's favorite measures and questions to get down to a 2-page questionnaire. The items at the bottom in italics are things that we've added in the current version that we're presently validating, and that is that we realized that we didn't have enough questions about families of infants and young children, that the traumatic stress work that we were doing was growing, and that we wanted to include some questions about that. And we also added items related to suicidality. From those domains, there are subscales. This is based, again, on sort of now what I think of the earlier version of the PAT, not the current PAT that we're testing. So you can see these subscales, which get at, how many adults are there in the family? Do you have trouble paying your bills? Things like that. Family problems, social support, the acute stress reactions or the traumatic stress markers. We look at child problems, sibling problems, and family beliefs. Family beliefs behave the worst psychometrically. And if someone says, I want to give a shorter version of the PAT, and I say, well, okay, leave off the family beliefs. Oh no, they're so interesting. I don't want to leave those off. So almost nobody actually removes them, and I hope that someday it will become clearer what it is that we're measuring. But we wanted to really use plain speaking. So there are things like, this is a disaster. So it's interesting information to know, but a little ambiguous to interpret. Because indeed, we score the items based on the research literature and clinical expertise. You get a sum score. It maps on to the triple PHM based on standard deviations, basically, for universal, targeted, and clinical. We also pull out in the scoring, there are some items that actually didn't figure into the scoring because they're infrequent, but they're important. So those are highlighted on the reporting. So PAT is now available in a variety of formats. The paper and pencil is still the nicest to look at, but we don't use it anymore. The standard administration, certainly for a research study, is REDCap. PAT has been integrated into Epic in a couple of places. This is an iPad that's used at Cincinnati. And recently we've opened up our website, which has the English and Spanish, and you get immediate scoring and a clinical report from that. This is kind of I think, a very nice example of where we can go with the electronic health record. This is my Nemours, the patient portal at Nemours. This happens to be an adaptation of PAT that we're using in the weight management clinic, but families are asked to complete this before they come to their first clinic visit, and if they don't, or they're not able to, they are the clerk, the check-in clerk helps them register and complete it, so that when the physician goes in to the room to meet with the family, they already have the scored PAT results in their Epic screen. We're doing a study of that now. So I see my clock counting down here. This is psychometric data on the PAT. This was published in 2008. I won't dwell on it except to say that we were very happy with the psychometrics of the PAT and its ability to predict things that we thought were important, such as child problems on the BASC-2 and acute stress reactions and parental anxiety. Our current study is funded by the American Cancer Society, and in this we're validating a Spanish version of the PAT. It's part of the Health Disparities program at the ACS, and it's also going to allow us to do a nice validation and revalidation of the English PAT. So you can see this is at CHOP, MD Anderson, Nemours, Wilmington, Orlando, and Eric Sandler and I are hoping to open it in Jacksonville as well. So when I said the triple PHM was not drawn to scale, I just want to show you how this plays out, clinical, targeted, and universal. These are all studies on pediatric cancer. And what you can see at the universal range, from about 50 to 75%, that's pretty consistent across sites. So when people say, gosh, what's going to happen if I give this? You know, how are the families going to fall out? I say, well, the majority are going to show resilient, sort of universal functioning. Targeted, 24 to 36, and clinical from a low of 4 to a high of 18. This is fairly consistent. These are people that use the PAT clinically, not as part of a study, and you see a fairly consistent pattern there. This is our current study from the ACS, and these are brand new data. It's an ongoing study. I don't want to make too much of it, but I can't help but notice that we're seeing 8% of the English-speaking families in the clinical range and 16 for the Spanish. So we're obviously have to continue collecting data there. I already mentioned the possibilities for some of the interventions. One that I just want to bring to your attention for the universal level is a website that we've developed as part of our center in the National Child Traumatic Stress Network, and that is healthcaretoolbox.org. Our idea here, as part of the NCTSN, is to raise the standard of care for traumatized children and families. And our mission is specifically to help do that in the medical system. So I would encourage you to visit this website. An important part of this is the DEF in trauma-informed care. So after you've stabilized the patient, you've completed the ABCs, the DEF. We all like mnemonics, right? Reduce distress, provide emotional support, and remember the family. As a lot of people say, I know I'm supposed to do something else. We've done some work with EMTs. I know that I should be saying something to the child and the family in an ambulance, for example, but I'm afraid I'm going to say the wrong thing. I'm afraid I'm going to make things worse. So the idea of this is to provide tools and resources. And families also come to this site and are welcome to come to this site, and we have materials when you drill down through some of the links that are helpful for everyone, hopefully. I just want to say a little bit about challenges to screening, because why aren't we all doing this, right? It's important, it's mandated. I guess a couple that particularly that haven't been mentioned is the stigma. You know, I'm a psychologist. I know people don't always want to talk to me. Well, maybe they don't want to talk to me for other reasons, but or the message that people get about what it means to say, I'm having a hard time, I need to talk to someone. We're not really big on that in this country. And I think that families also get messages sometimes from their healthcare providers. Well, if it gets to that point, we'll refer you to Dr. Kazak, but you know, you're okay. Well, we want to get away from that. We want to be able to get that information up front. But stigma is a big one. Time is a big one. You know, and challenges, I think we can sort of say, how long does it actually take? The PAT takes people 5 to 10 minutes to complete. Getting it into the clinical workflow is another question, and that's gonna vary, but we're seeing people being able to do this, particularly with the web-based versions. So I'm running out of time, so I won't go on there, but I think to sustain screening, people now are looking at billing codes for screening time. They're beginning to link them into pathways of care, so some nice implementation is happening. So just a couple of conclusions here. In order to roll out more interventions, we really need to know who is available at treatment sites. And it's not so easy to tell. People often say, oh, when I was at CHOP, they say, oh, you're at a big place, you have all these resources and all these people. It's not that simple. So I think we need some data on that to know, do we have the resources in place to begin to provide more evidence-based care? You've heard a little bit previously about the Psychosocial Standards of Care project. I don't think what was mentioned is we're actually publishing a special issue of Pediatric Blood and Cancer, hopefully at the end of 2015, on psychosocial standards. There's a lot of people here that have been part of that work, and that's really, I think, going to set us up to say, what are the next steps to push this out into the real world? Well, families are important. As we rush to screen, I hope that we don't short-sight the value of looking at the whole family. We haven't talked about child input in screening, and I'd be glad to think more about that with you during the discussion, if that's of interest. And what's the sequence? What happens after we screen? And I'm beginning to play with some ideas around this, that you screen, then you assess. A lot of times people say, oh, you don't ask about this or you don't ask about that. And I say, no, it's just a screen. You still have to go and say, based on what you've told us, let me learn more about this problem in order to treat, to test, did the treatment work, and to track over time what happens. And then I think ultimately when we do screen and when we figure out when the best times are to screen, we need to know if that leads to more effective treatments that in fact do match families' needs. Does it promote adjustment? And does it help us deliver that care earlier or more effectively? I don't think that anybody has talked about a new book that is just out. Lori Weiner is the lead author, and a number of colleagues, including myself and Mary Jo here. But this is a re-release, second edition of Pediatric Psycho-Oncology. It's just out, hot off the press. So another resource to consider. Okay, thank you.